Thank you. Hold on.
And Shelley has hit the record button as well.
All right, so we'll go ahead and call to order this meeting, this standing committee special meeting for protocols, medications, devices. It's Thursday, June 16th, 9:05 in the morning. Shelley, can we get roll call, please?
Amber Rice.
Present.
Erin O'Connor.
Present.
Brian Smith.
Present.
Chester Key. Bronco Castromarin.
Present.
Garth Gamer. Heather Miller.
Present.
Jason Johnson.
Here.
Josh Gaither. Matt Shaw.
Present.
Paul Dabrowski. Shari Brand.
Present.
I count 8. We have quorum.
All right, thank you. So we'll go ahead and get straight to it, folks. Can I get a motion to discuss, amend, and approve the T3G updates?
So move, Brian.
Can I get a second?
Second, Shari.
All right, thank you. So that goes ahead and opens up discussion. Shelley, did you have a preferred order, or shall we go according to the agenda?
The updated agenda that's attached.
All right, so that shows, I've got that open. I shows Dr. Brand to open it up the conversation here with the pediatric section.
Franco, just a couple housekeeping items to remind everyone. We are recording the meeting, and per open meeting laws, anything recorded and said or showed on video during the meeting is part of the formal recording, which is posted to ADHS's YouTube site. If you are joining by phone only, press *6 to unmute yourself. Otherwise, if you could please identify yourself before speaking, just so that we can track that from a virtual meeting perspective. And I will turn it over to Shari. We will also project the guidelines as she's kind of reviewed them. I know one other request, Dr. Rice does have a conflicting meeting, so we may ask if the group's okay with moving her section earlier on the agenda, if that's okay.
Hey, Gail, I got my other thing covered this afternoon, so I'm okay.
Okay, perfect. Thank you, Amber.
I mean, they're looking at content, not format.
Okay. Shelley, are you just going to pull up this slide and then we can talk about it? Is that the plan?
Yeah.
Yes,
Let's
thank
see it
you.
on. So that would, are we starting with pain, or do you want either one? I can start with pain. The biggest, so this was a pediatric, and then pain was included, kind of tacked on. So the biggest changes that I saw, and this is kind of a point of discussion, is they added on for minor pain and as an adjunct for moderate pain, acetaminophen and ibuprofen. Now, we only have in our medication approvals, when we talked about OTC medication, it did not specify. So there's a line in here that I added that we can either take out or keep, because we have no specifications for, you know, those specific medications. We never went through PMD and to approve those, but we do have something that just generalized says OTC meds.
And Shari, just because it's not showing the change on here, is it the bulleted consider OTC pain medications?
Correct.
And would that be just for adults only, or is that for discussion?
There was a pediatric portion. I mean, it does talk about it for Tylenol in pediatrics, like, you know, so they do give doses, and you know, there are recommendations for doses on there and amounts. It's just a matter of what do we want to do, because we don't have it specified, like I said, in any of our drug lists. So they've got for ibuprofen actually greater than 6 months of age and the acetaminophen, but they, and they have it out by per kilo doses. So I wasn't sure what the group, just because that was kind of a strange area, a little bit of a gray area.
Hey, it's Erin. So are we saying, do we need to just include the ibuprofen and acetaminophen with the appropriate dosing in this particular document? Is that?
Well, that's part of the question. The issue is that we don't have that in our drug list, but we do have in the protocols OTC meds, but we've never specified what those are. We've never like kind of opened that can and gone into, can we give, are they carrying it?
Could we, this is Jason, could we get around it by saying something like, consider OTC pain meds such as acetaminophen and ibuprofen?
I guess the question is, do they keep it on their, is it part of what's accessible to them? Because if they have it stocked and accessible to them, then I think we need to somewhere document dosing. If they don't, then I think a more nebulous statement is fine.
Right.
Yeah.
Because we don't have it listed on the drug box.
So Shari, it is actually listed under, it's vague terminology on page 3 of table 1. It's listed as over-the-counter analgesics for pain or fever. So we don't specify acetaminophen or ibuprofen, but we do have it listed generically.
Right. Which is why I had done it this way, and I didn't know if we leave it up to medical direction for dosing, or do we put in dosing or make that was kind of that gray area. But
I would like, I like the idea of putting in the dosing here, because then of all the OTC medications that could potentially be given, I think honestly ibuprofen and Tylenol are going to be the two that are most likely to be given.
So, like I said, there are parameters for Nasemso for it, which would be, maximums and, age minimums. I can certainly add those in.
And I apologize, I don't have, I'm up by Yellowstone, so I don't have a whole lot of stuff on my computer. But is it under the EMT scope of practice for OTC meds, or
Yes.
is it's not a paramedic scope? Okay.
No, we have it listed at least for OTC meds on the drug box across
Across the board. Okay. Thank you.
I'll say I agree that we should include the dosing in this document. If we refer to it and we want people to possibly utilize them, then we should give the guidance of the appropriate dose. I think the other thing that we could consider is the optics of, trying to do opioid sparing. If our first medication is an opioid, maybe that doesn't look so great, and maybe an NSAID or an alternative analgesic is important to have listed.
Okay. Then I can, if the group agrees, I can add that back in.
Shari,
Just didn't know how.
do you have the terminology so that way we could potentially vote on that?
So it's minor pain as adjunct for moderate or severe pain. Acetaminophen 15 milligrams per kilogram, PO or IV, although I'm sure they're not carrying IV. Maximum dose 1 gram, and then it's non-steroidal anti-inflammatories, ibuprofen 10 milligrams per kilogram, PO for greater than 6 months of age, maximum dose of grams. And they actually have Torlac, which we don't have in nitrous, so I wasn't even going to include those.
Is there a way, Shelley, to easily flip back and forth to the Nasemso guidelines so we can all look at the same verbiage? She's referring to page 93.
Yeah. Sorry, it's page 3 on Nasemso. At the very bottom.
We are working on that right now.
if we're looking into, I also agree with Jason that if I would rather have this spell out the two medications, acetaminophen and ibuprofen, with the doses as listed. I would ask if there's anyone who would take a look at that 800 milligram maximum ibuprofen dose. I'd probably make an argument to scale that down to 600 milligrams. My understanding from the literature is that once you get over 600 milligrams, you start to crank up the adverse reactions a little bit and don't really get much more benefit in terms of pain control. But I haven't looked at that literature in a long time.
Yeah, I agree. In my own practice, that's 600 is the most I give.
I'm
I
with you.
agree. Yeah.
So I can add. And is there any problem with putting it in with it not being specified in the drug box and not going through the regular medication vetting?
It is specified on the drug box list.
Right, as OTC, but
Right.
We just don't have profiles, I think is what you're getting at. We don't
We
have
could
drug
build a
profiles.
correct. We have
profile
no
for it.
profiles and we never,
Yeah, we could build a profile for it, could we not? During this session, during this edit window?
No,
Yes.
that have to be on the agenda.
I see.
Yeah, we
we
can't
could
do that today's meeting, but we could definitely, we've got plenty of time before this would go live in hopefully before January. So we could absolutely get that on one of the upcoming agendas.
Yeah, I think that's a great plan, is like to get it into the protocols today and get it as a profile at a future meeting.
okay. So then if we're all in agreement, I will add that back on.
Sorry, there's just a question in the chat quickly. So we can't endorse parental dosing. We don't have patient assistance scope of practice anymore, Dale, but we can certainly, it's certainly an option. Anyone could have the parent could medicate the child if they wanted to.
Understood. Thanks.
So there would need to be a caveat, is what you're saying, for parental?
No.
No.
Nope.
Okay.
We just,
So just keep it off. We
correct.
think rental or like IV is
Parental thing, meaning parent,
here. Okay.
parent/guard. I think that's what Dale meant.
Okay.
Yes.
There's a
So that
I'm
was just gonna-
parental versus parental. Tomato,
Parental.
tomato.
Exactly.
I lost the nuance. Okay, so that was one of the changes that was added on. One question I did have was, did we want to, we have hyperlinks to FLAC and the Ontario pain scale. Do we need hyperlinks do we have to put in like the Wong Baker or the numerical? Do we need those as if we're referencing them?
Yes, we do.
Okay, so those need to go in then as hyperlinks. And I did not know how to do a hyperlink, so that was my,
Shelley's got you.
okay. So I would do hyperlinks to those and make sure that we have those. And if we don't, I'll have to put those in. And then if you can move down a little bit, the only other thing that was added on was for AMT, because they're able to give morphine using Untitled CO2 as an early predictor of hypoventilation. So just a reminder that they can be on N-Title. And then finally, I put in for a consideration for EMTI and paramedic with the narcotics, if they start having nausea, vomiting, a hyperlink to the nausea and vomiting algorithm.
And
So
did
that
you
would be-
want that adult and peds or just adult?
Adult and peds. So those are really the only changes.
So Franco, what might be easier, just so we can track this well, is maybe take, as we complete each guideline, just take an approval per guideline, make sure we get a vote on those and then move to the next
Okay.
one, if you're okay with that.
All right.
The-
Any additional comments on this page? All right,
They
hearing
had-
none.
Oh,
Sorry.
I want to say. No, just ignore me. That's fine.
All right. So here, no additional comments, and let's go ahead and take a vote on approval of this pain management.
There was one other thing that I did not add on, but because we have a max dose of morphine of 10 or of 15, they have a max initial dose that they start with of 10. Did we want to put that in at all? We have a max total dose, but not a max initial dose.
So
We have it as 2 to 5, as we have it pretty
Increments.
small as 2 to 5 increments. Did we want to keep that as the question? Because Nasemso was talking, like, they don't have the 2 to 5 increments, and I think we're just starting smaller to see if we can get there. They have an initial max, a maximum initial dose of 10 is what they put, but we're starting with an initial max of 2 to 5.
Right.
So do we want to increase it at all, or?
I think we spent a decent amount of time before kind of debating this, and it gives an ample amount, you can go up to 5 milligrams, and there's not a specific time frame for redosing, so.
This is Dale. I'm a little puzzled. I mean, we define the dose, and the dose is defined by the weight of the child. Then we say, well, you have a range. That seems counterintuitive to me, because the 0.1 per kilo already defines the dose, but then we say max 2 to 5. I would think you would just want a single max, because you're not giving a range on the dose. If you had 0.05 to 0.1 as your initial dose, then you're going to have a range for your max. But I agree that the max of 5 and the total max of 15 is appropriate, but I'm puzzled as to why there's a max range. It's semantics, but just a comment there.
I think the history, we spent, a lot of time trying to get a dosing range that the committees were comfortable with the last time, Dale. And I agree, it is unusual, because this is probably the only one that with pain management, that we have this type of kind of weight-based dose with then a max initial dose plus a max total dose. And the concern was just to make sure that we don't have potentially young children who are larger sized, or elderly patients that are smaller sized getting a very large base dosing that maybe could have an adverse event. So with the recognition that we want to kind of get people to think about weight-based dosing to cover adult and peds, but for pain management, you can always give more of a pain med. It's hard to take it away if they have an adverse reaction. Does that make more sense?
Yeah, I understand that. Yeah, it's just the range, but yeah, totally agree. Want to be cautious with dosing. Thank you.
So that was it for it.
All right. Well, can we go ahead and take a vote then? All those in favor of approving this pain management page as is with the edits as shown, say aye.
Aye.
Aye. Sorry, I just saw something pop up on the chat box. Did somebody raise a hand? No, okay. All right, any
I raised my hand. Aye.
yeah, go ahead, please.
I was just saying aye. Sorry.
Okay, got it. All those opposed say nay.
She's on staying, I think.
Any abstentions? All right, so this approval passes. We'll go on to the next page, please.
All right, and Franco, just a reminder, the only voting members are members of PMD, so we just need to clarify, only members who are on PMD can vote.
Thanks, Dr. Bradley. All right, so the next page is pediatric respiratory distress, wheezing, less than 2 years old.
Okay, so now this had been in the original one too, and for some reason we kept it out. I think it's still reasonable to put it back in though. What we had to find on our regular one was just less than 2 with wheezing and diffuse rhonchi. They specified pretty closely that it's, viral or undifferentiated with upper respiratory, with upper respiratory symptoms associated with possible respiratory failure. So we had just kept it incredibly broad with just wheezing and rhonchi in a child less than 2. So I had added the other on if there's no question with that.
So what you're saying is that you re-added
I
a
expanded it.
specific
I don't
page.
know why it wasn't included originally, because when I went back to the 2.2 version, it did look like there was some semblance of that wording in there.
Mhm.
So I'm not sure of the history on why it was kept out.
But this wording is the wording from NISMSO. Is that what you're saying, Shari?
Yeah, no, this is the NISMSO wording, and it had been present on the prior version also. We had showed, like, for some reason, we didn't have it in there. But I wasn't quite sure why. Because it's pretty specific for bronchiolitis. So unless there was some reason when you guys did the initial one, that wasn't a change in it, but it just was never included in ours. If that makes sense. As the inclusion criteria. So I put that back in. For EMT, an SpO2 goal range was added, or was in there, as well as for them to monitor pulse ox, because they should be able to monitor pulse ox. The biggest changes were in so I put end title in for AMT, because that level down should be monitoring it anyway with respiratory issues. And the epi dose changed. So previously for us, we'd had 1 milligram per ml with 3 mils and 3 mils of saline nebulized. They just have it as 5 milligrams. Now, that being said, when you look at the drug boxes, unless the drug boxes are carrying like 30 milligram multivials, they may not have enough to just do singles.
So, Shari, can you specify what the original verbiage that we had looked like?
The original verbiage was 1 milligram per milliliter, 3 milligrams. So 3 mils in 3 mils of normal saline. Now it's just 5 milligrams of epi.
Could you do something, say up to 5 mLs? That way, if they have the 3 and that's all they have, they could use that.
Well, they may not even have the 3, because the minimum on the drug box list of 1 milligram ml concentration is 2.
Mm-hmm.
Yeah, so if you just said up to, then if they had 2 or 3 or 5, whatever, it'd be kind of, leave it a little more generic, so that way it would fit to any agency.
So you want it up to?
I think that's the easiest way to kind of put in a max, but ideally if they could carry 5, they could give 5, but knowing that, like Brian said, if they only have 2, they give 2.
I have a question. If it's 2 mLs of epinephrine, don't you want to mix that up though with some normal saline to where you have at least 5 mLs in your SVN? Because right now,
You mean if they're giving a lesser amount,
5
Brian?
milligrams, you're going to have 5 mLs, so you wouldn't need to mix it. But if you're going to have less than that,
So the typical nebulized apparatus holds a 3 milliliter ampule, which is the common volume. Both the in-stock racemic and the code epi are in a normal saline-based solution. So I wouldn't think diluting it would be of any benefit. But 3 milliliters typically nebulizes over about a half hour, which is the duration of most transport times.
So just to remind everyone, so the current version of the T3Gs, I wish I could, I just tried to put the screenshot in the chat box, but it looks like the chat box isn't formatted to accept screenshots. The volume that's specified is 3 mLs. There's actually a typo in it. It says 3 mLs in 3 mLs of normal saline. It should read 3 milligrams in 3 mLs of normal saline. And so, I would probably suggest that we keep it as is, and then add, if the group desires, put that low end of 3 milligrams in 3 mLs, and then if it pleases the group, we can say up to 5. If our underlying goal is to keep as close as possible to the NASEMSO guidelines.
So you're saying put in right before it says up to, you'd put in 3 milligrams and 3 mLs up to 5 milligrams nebulized.
Yeah, exactly. So I would say, so the sentence should read 1 milligram per ml, comma, 3 milligrams. And then, let's see. And then here we had a bracket, and then we explained 3 milligrams in 3 ml NS. Close bracket.
ML and then space N as Nancy, S and Sam capitals. No, after.
Normal saline.
Yeah.
And ml we don't make plural. We just say ml. And then you can simplify. You can say up to 5 milligrams, and then just put in brackets 5 ml, and then delete the rest. Keep the word nebulized.
So one of the things I'm just going to throw out, I just want to make sure if we have any kind of paramedics that are on the line, is this going to be, I read this and I'm confused as to what we're suggesting dosing wise.
Yeah, I agree, and then that's kind of why I mentioned. I mean, it just depends on how important is our goal to stick as close as possible to the NASEMSO. I mean, I guess the original point that was just made was that we're not sure if crews are carrying enough epinephrine to go up to the 5 milligrams. So how married are we to the concept of going up to 5 milligrams if we're thinking it's not going to make a clinical difference?
Well, hi, it's Brian. We're still carrying 30 milligram vials up here, but I can tell you they have had periods where they're really hard to get, and they're being incredibly expensive to maintain. So since they're optional, the question is anybody out there really carrying more than 2 milligrams of 1 milligram ml concentration in their, either in vials or tubexes or whatever?
Well, then the question is, I mean, there's an optional 30 milligram dose vial. Is that something that's
the one I was saying can be hard to get, and it is getting incredibly expensive.
so that one's more expensive? Okay.
Yeah, it's I think the last time I looked from Boundtree, it was verging up on around the $175 plus mark for the 30 milligram vials.
Because the dosing changed for croup also to the same thing. So it's the same nomenclature for croup as it is for bronchiolitis with the 5 milligrams.
So can I just maybe make one suggestion? So in the central region, who kind of adopted the TTTGs and really converted them and have been using them in this format in the Central Arizona guidelines for several years now, the dosing has read 1 milligram per ml, comma, 3 milligrams, and then in parentheses, 3 milligram diluted in 3 mLs normal saline. And it seems like that dosing and verbiage has worked well for the last 3 years. I'm just trying to find a way to potentially streamline this. I have a feeling that if we're saying 3 milligrams up to 5, that's going to confuse people. So just a consideration that if 3 milligrams is a routine dose, which it sounds like Dr. Woolridge is saying that's a reasonable dosing for a 30-minute transport, I think that would get a lot of the state covered pretty adequately.
So you're
Right.
saying it, Gail? And put it with the Central Arizona nomenclature?
I would, and just consider saying we reckon, taking off that up to 5 milligram and then 5 ml portion.
Okay, so then if that's the case, do the 3 milligrams, and you're saying add in there diluted in, because that makes it clearer?
I think so. I mean, I think that was feedback that we got from crews who are trying to use this dosing.
Okay.
So
So if that's the case, then we're taking out the 5 milligrams and 5 ml, and we're for 3 milligrams, it would be parenthesis 3 milligrams diluted in 3 milliliters normal saline, and leave it at that. And we just keep it at the basic, the prior.
Correct. So
Okay.
just be after 3 milligram in the parentheses,
Put in
just
diluted.
diluted.
So it's just a matter of we'll just veer from Nisemso for given limitations in supply and ease, I guess.
Right. Well, even with ours, sometimes we do have transports that are an hour plus, but we've just did it the same way that Gail was saying, is we have them do the standard 3 milligram. And then if they need another one, they can call for online medical direction to give a second dose, which puts it to 6 milligrams, but it's not that much of a difference.
Right.
And
Well, now
that's-
it's closer to guidelines, so it's not too
Right.
far.
I agree. And then that way, if you need to give a second dose, you've gone up to 6.
Right.
But I like keeping it at this because even with our prolonged transports, it's really rare to have a kid who falls in this category that will be transported an hour. Most of ours are within that half hour. And if we do have one that's an hour long, then they just call in and say, hey, I want to give a second neb.
Okay. So let's see real quick. The other things that, if we're going to leave that, the other things I changed: impending respiratory failure. We just had it as respiratory failure, but they've got BVM for impending. And then the question I had, I added the airway management. Once you're getting into severe respiratory distress, we really should probably be hyperlinking them back to the airway management algorithm. And so here's my other question, and this fits into other areas too. So AEMTs can do it's an STR for EMT, but AEMTs can do supraglottic. We have, AEMTs can do CPAP. So we have non-invasive down, but we only have it under EMTI, but we have that listed with high flow nasal cannula, which is only paramedic. So we're kind of mixing scope of practices.
Shelley, I think that's because when we did this before, high flow nasal cannula was not in scope of practice for anyone. So
Okay.
that's been added to scope of practice. So what we could certainly do, probably the cleanest way, would be to link from both AEMT and EMTI/paramedic, link to airway management, and that would take them to their correct listed scope. And we can make sure that airway management is just up to date with the updated scope of practice.
Okay. So we're taking out, so we'll just put up here it'll be another slash for linking to airway management, or I would make that as a separate, there you go. So link to airway management outside of epi, I would even just do it's because it's under for respiratory distress. So that would go back as a slash, not a circle.
Yeah, don't worry about the format part. We'll take care of that.
But no problem. And then, so then we're going to I'll have to redo the EMTI for severe respiratory distress unless they specify high flow nasal cannula in here now and positive pressure. So we're just taking that out and just throwing them to airway then for both areas.
I think that would be the cleanest thing to do, because otherwise we do have some confusion, because we have with the few EMTIs we have left in the state, they have a very limited scope compared to paramedics. And so as we look at some things that are very specific to paramedic versus EMTI versus AEMT, I think if we just refer them all as they escalate to airway management, we can make sure that airway management has the correct scope items listed versus trying to fix it on each guideline.
So we're taking out that entire box and we're just moving airway should be managed in the least invasive way possible up.
Yeah, I see what you're saying, Shari. So it's basically really, when it comes to airway management, there really should be no verbiage difference from AMT to AMTI and paramedic. It should all be shifted up to the AEMT box, and by default will apply to both scopes of practice.
Okay. So, I mean, so then for the purpose of the slide or the actual thing, the entire EMTI
Yeah, I see
paramedic.
what you're saying. Yeah, so I agree. If nobody has any objections, is basically all that language that is currently shown under the EMTI paramedic box would be shifted to the AEMT scope and therefore apply to all three of those scopes. And then the only difference among the scopes would be spelled out when they go to their hyperlinked airway management page.
And I think actually, Shelley, the bottom two lines under EMTI/paramedics, so supraglottic and airway. Yep, so I think those two as well. And then it would just be a blank. Yeah, there has been a pretty significant change to scope of practice since we did these last. So we may, as we go through these, find some of those changes. So thank you for picking up on that.
Because we'll have the same thing in this, in the group one too.
So,
And then in order to remove any reference to the word intubation now, would anybody have any objection to saying invasive airways should be utilized only if BVM ventilation fails? That way nobody gets confused that AEMTs are intubating.
Or advanced airway.
or advanced airway.
Oh yeah, there you go. Advanced airway. Yeah.
Mm-hmm.
I have another question. Is that airway guideline going to include non-invasive and high flow nasal cannula in the appropriate level? Because right now we're showing the high flow nasal cannula in AMT, and it's not in the scope of practice for them, only paramedics.
Yeah, we will get to airway management down the ways. Yes.
Yeah, right. So it'll say for severe respiratory distress, refer to airway management.
So the other thing we can do is we can do a parenthesis and say paramedic level. I mean, we've done that on others where when it's together, we've specified
Right.
But
paramedic.
that's only the difference between EMTI and paramedic, not AEMT. That's when we're trying to make the difference between, because we have the EMTI and the paramedic in the same box. If it's not in the EMT scope of practice or EMTI scope of practice, then we have done that to say paramedic, but it wouldn't, we wouldn't be doing that based off the AMT, because everything in the boxes above automatically moved to the next box.
But for the high flow nasal cannula portion, that would still hold true because it's only a paramedic scope. It's specified for them.
Right,
we're
but
not-
then we
if
should
we're moved-
put
but
that.
we've moved
we
it
should
up.
Put that we should put if we're not gonna have that as a part of going to the airway management, we're gonna have it separate. Then we need to move that line down into EMTI and paramedic. Say consider high flow nasal cannula or something like that, and then behind that there would be paramedic only because it's not approved for the EMTI scope practice either.
So we're trying to do real-time editing, which you can't really do very well on this. So just to clarify, we are going to add in right here, instead of all this for severe respiratory distress, refer to airway management.
Right, that was what I was asking.
And then we are going to
Erase.
take off.
There we go.
And then this should be advanced airway should be only utilized if the BVM fails. Ventilate airway should be managed in the least invasive airway possible. So then this will be a hyperlink here. So that would hyperlink us to airway, and we'll make sure under airway management that we have everything updated for scope of practice. Does that make sense?
Remember this because we're going to need it for the next slide. I'm just trying to make notes.
Yes. The good thing about Google Docs is that it saves all these changes. You can go back inordinately. So, so does that formatting work and make sense? Obviously, we'll take care of all this over here in terms of making sure it's left shifted and everything. But
Yeah,
it would
and then
basically say,
paramedic goes with the IMT. Okay.
yeah, for severe respiratory distress, report to airway management. I think all of these things still make sense underneath that.
Yep.
All right. All right, back to you, Franco.
All right. Anything else on this page? It looks like we've got that all cleaned up now. Any other comments? Hearing none, let's go ahead and take a vote. All those in favor to the edits as shown for pediatric respiratory distress, say aye. Voting members only, or I'm sorry, voting to PMD members only.
Aye.
Any opposed? Any abstentions? All right, the motion passes. Next page, please. All right, the next
Okay.
page is Pediatric Strider.
Okay, so for pediatric strider, I did add back on epiglottis. We didn't have that as an exclusion. I think now, especially with vaccinations being kind of waning a little bit, we may see resurgence. I don't know. But so I added that back in, and that has always been in the exclusionary criteria. As far as other changes, it's the respiratory distress part under AMT. So I added guidelines in for SpO2 of 94 to 98%. And then for respiratory distress with it's a Strider with Strider at rest, they specify. And then we have the same issue with the epinephrine. So if we can change that back to what it had been on the other, if we're using the same criteria with the 3 milligram and we're going back. The difference is this is Q20 unless they're have ongoing distress, and then it's unlimited, which we had before, that it was unlimited.
And Shari, just to clarify, we're going to match this with the bronchiolitis one or the original croup one?
The original one was, let's see, we had originally, the original one was 5 milligrams for, here's the thing is pediatric Strider was 5 milligrams diluted in 3. Is what our original guidelines are. So we were having them do 5 for Strider.
Yeah, and what was just stated is true of the Central Arizona guidelines. We still show 5 milligrams diluted for pediatric Strider.
So we're back to either we're standardizing it, and that's the other thing. This would have standardized it for both to 5, or we're dropping croup down. Because if the expectation is that they're giving 5 for croup, why aren't they giving 5 for the bronchiolitis if that's national standard? So they shouldn't be able to get it easier for croup. Either they're going to have the drug or not.
So just for some agencies on the line, it would be helpful. I know we heard one, Brian speak to the fact that up north it is expensive and hard to get. If there's maybe some other agencies that could also weigh in, because I know I have heard from several agencies that this is a little bit cost prohibitive. So I would be interested to get that feedback. And then potentially from Dr. Woolrich and Dr. O'Connor, kind of their thoughts on if this was listed at 3 milligram, would we be underdosing this patient population?
Gail, it's Aaron. I don't know if I have a comment. I don't know if I have anything meaningful to add.
This is Dale. I'd make a comment if I could. Hospital-based dosing for nebulized solutions. If we do racemic, it's the 0.5 milliliters reconstituted to 3 milliliters total volume of normal saline. If we do albuterol, it's a 3 milliliter ampule. So if cost is a concern, why are we pushing to nebulize a full 5 milliliters when the standard ampule nebulized is 3 milliliters?
Well, I think the question, Dale, is are we causing any problems with this 5 milligram versus 3 milligram distinction?
I mean, the solution is pre-formulated. It's already in its sustained volume of 1 milligram per milliliter. I would think it more reasonable to say you have a 1 milligram per milliliter solution, then nebulize this amount of volume, because we're not rediluting it. We're just nebulizing the volume that's already the formulary. And maybe I'm talking circles around, what is customary, but the solution is pre-made. Then we tell them to just nebulize the volume we want them to nebulize.
Right, but I guess what we're trying to ask is, can the overarching driving values that we're looking for is to try to minimize confusion, stick as close to Nasemso as possible, and of course, with an eye towards cost and supply chain limitations across that have the most impact across agencies across the state. So it would be a win here, I think, if we could get both doses the same. But if by doing so, do we put a specific disease process at a disadvantage? That is, if we dose croup at 3 milligrams, are we disadvantaging, putting croup patients at a disadvantage? Because the guidelines are all at 5 milligrams for this disease process. Does that make sense?
Yeah, it does. Yeah, that does make sense. Thank you, Franco.
So we have a comment in the room here as well.
Brandon Burgess, Phoenix Fire, from a practicing paramedic in the field and not from an administrative point of view. I would appreciate it if we could simplify these things. So we're not dealing with multiple different dosages if those multiple different dosages are not medically necessary for a specific disease process.
Hi, it's Brian.
Hold on just a second, Brian. Someone's speaking. Thank you. Sorry, I think that I accidentally muted you. Can you repeat that again? I muted you halfway through.
Hello, Brandon Burgess, practicing paramedic, Phoenix Fire Department, not in an administrative role, purely a field provider. If we have multiple dosages, but they are all medically acceptable for a specific disease state, and we can make them identical, it would be much easier for all the field practicing paramedics. Obviously, we understand if there's a specific disease process that requires a higher dosage, that certainly must be mandated. I am confused with the comment about the 3 milliliter volume. Is my understanding you want me to administer a total fluid volume of 6 milliliters with my epinephrine SVMs? That's question number 1. Question number 2 is, if I understood the discussion previously about the amount of epinephrine, if we have agencies that are only responding with 2 milligrams of 1 to 1,000 epinephrine, why are we having the discussion regarding 5 milligrams of epinephrine if the paramedics aren't responding with that amount of drug in the first place? Thank you.
Hi, it's Brian.
Go ahead, Brian.
Well, that was what my comment was going to be related to, is that I think if we're going to do this and we're going to have a recommended dose that's higher than what people may be carrying, that we need to move at the next PMD to adjust the amount of 1 milligram ML, either vials or 2X's or however people are carrying, so that on that line it moves from 2 to 5. I don't see how we can say you only have to have 2 minimum. The 30 milligram vials are optional. We made those optional, so it would seem like we should move that to 5 milligrams so that everybody has the amount they need to administer at least the minimum quantity we're requiring noted in these guidelines.
Shelley, this is Franco. Do you happen to have in the Google Drive the drug box list so that we can all take a look at that?
And then, and this is Jason. I agree with kind of what Brian was saying. We're putting this together for this is the national best practice. So if people aren't carrying the full amount, they're basically not doing the best practice. So I think it kind of going along with what Brian was saying is if we expect them to perform at this level, we should almost mandate that they're at least carrying the minimum medications required to perform at the best practice level.
Okay, so it's being shown now, just for the sake of the audience, we have the EMCT drug box. If you could scroll down to epinephrine, just to remind everybody what we're concerned with here. So we, obviously we're getting away from the nomenclature, the ratio-based nomenclature, or I'm sorry, the what is it? The I forget what the terms are. The 1 to 1,000, 1 to 10,000 nomenclature, and we're just going with the concentration. So it looks like we've got 2 milligrams mandatory. We've for 1 milligram per ml, which is Brian's point. And so because of cost and other supply chain limitations, it sounds like some agencies have moved towards just doing that minimum required. We've got an optional for the 30 milligram multi-dose vial. And then we've got the 5 milligrams of what's traditionally the cardiac epinephrine carbajets. So, Gail, can you walk us through what it would take then if we decide as a group to stick with these 3 and 5 milligram doses? What would we need to do regulatory wise to change this table?
The drug tables we can update through PMD and MDC, so that is referenced from rule directly to this, so we don't have to wait for the rule writing process to be opened. So we could certainly update this at a future meeting. We could add an agenda item to recommend the adjustment to the drug table, and then that would go to MDC for final approval. So that would be an easy change if the group wanted that.
And then let's say we make 5 milligrams the mandatory minimum, which would then allow us to do whatever we wanted to the protocols. Any administrators in the room give us some feedback in terms of cost prohibitiveness and supply chain prohibitiveness there?
Franco, this is Amber. I know that we have regularly down here, at least in the southern region, have had multiple instances of epinephrine shortages and have had to get extensions and go through, a lot of processes to avoid having to apply for a waiver for some of the epinephrine concentrations, both of them. So I would be a little bit concerned about, nearly tripling the required amount of epinephrine, just because I think it could create some supply chain issues.
All right. And Dr. Woolrich, any comments from your perspective if we kept the minimums as is and acknowledge that there are superseding supply chain and cost issues? Do we disadvantage? Is it compelling enough of a disadvantage to these patients one way or another? Dr. Woolrich, you still on the line? Well, Dr. Bradley, should we table this or maybe break out a subgroup to take a look at this from a clinical perspective?
So I think one of the things we can go, if we can go back to the actual group guideline, what we can maybe do is at least look at the other suggested changes from Shari, and then just maybe highlight that we will come back to the epidose unless we come to a decision today.
And is
Okay.
that something that we could like approve everything else? And this could be something when we have our normal PMD meeting, that this could be one of the things that we add on to before we finalize it?
Yes,
Or is
we
this
can.
gonna be pushing it? Okay.
No, we can. As long as we cover each in an open meeting with opportunity for people to weigh in, we can certainly do that. The hope would be that we can at least come to an agreement on the rest of the terminology and that way streamline the process. So we're trying to do what has historically taken 2 years to get through the committee structure. We're trying to do this in a less than 6 month process so that we can get these updated for the 2023 calendar year for people's protocols and guidelines. So we may have to have another special meeting to accomplish that goal.
Yeah, and I think honestly, in my opinion, that's the way to go. So we kind of do it right the first time, and then if there is one or two little outliers, we could just finish them off at the PMD meeting. Otherwise, do another, even a short special meeting just to finalize some of these outliers.
Hey, it's Erin. Can I just ask, so our goal in doing these is going to be to not have a range of dosing, like so 2.5 milligrams to 5 milligrams is not helpful. Is that what we're saying? So that we have to choose a one dose?
Yeah, so I just put the sort of summary of remaining questions in the chat box. So the ideal solution is come up with a single nebulized epinephrine dose to treat both conditions, croup and bronchiolitis. Try not to put agencies in a situation where we're requiring them to increase their minimum epinephrine drug that they're carrying. And then, of course, the patient-centered concern, which is don't put either one of these patient conditions at a disadvantage by underdosing.
And I think to Amber's point, I don't think we will get through a higher minimum epinephrine. I think that dosing was decreased specifically for a number of reasons. Epinephrine seems to be a drug that goes into shortage very frequently, which means oftentimes departments are then going to getting kind of alternate versions of this that are diluted and pre-made from hospital pharmacies or some other compounding pharmacies, and those versions have a short half-life and are expensive. So I think we have more harm considering that this is our classic quote classic dosing that may really become an issue if we start requesting more of that. So I think trying to focus on, we've had these in place for a number of years. Let's pick 3 versus 5 and probably avoid changing on the drug table.
Gail, this is Amber. I completely agree. I think that we're really kind of overcomplicating this a little bit. I think for the transport times for most agencies, 3 milligrams of epinephrine is plenty to get you to the hospital. I think that if we want to say up to 5 milligrams before they call for medical direction, those agencies with longer transport times can choose to carry more epinephrine for those cases. I don't know that we have to make it more complicated than that.
But just to clarify, Dr. Rice, didn't we just see on the table of minimum required that the minimum required is 2 milligrams?
Okay, 2. Pick 2. I mean, say 2, but then say up to 5 or whatever. I know we don't like having ranges necessarily. I don't know any way around either having a range or sticking with 2. I mean, that seems like the 2 options to me.
And the minimum is certainly that's some agencies may choose to carry more than that, especially agencies who have longer transports.
Sure.
So it does not necessarily have to match. Again, these are guidelines that an agency and their medical director can choose to approve and alter as needed. And so an agency's medical director may say, you know what, our transport times average 5 minutes. We think it's sufficient to have 2. Another agency's medical director may say our transport times average 30 minutes, we want to carry 5. So I don't know that necessarily the dosing here has to match the drug table. We've not looked at it that way previously. We've really looked at what is the recommended dosing, and the drug table is a minimum option
Got it.
to carry.
So not concerned then that we might put a dose that an ambulance will not be able to supply based on their stocking.
Correct. An agency's medical director has to approve their guidelines, and that would also be including what is carried in their drug box.
Got it.
And I think a lot of those two combined decisions are really dependent on your transport times and your, number of apparatus as well as number of drug boxes.
Mm-hmm.
Okay. Do we just want me to finish the rest of the, are we going to go back to it later and for another PMD meeting?
Yeah, go ahead and finish up, Shari, on this page.
Okay, so we'll have to do the same thing with, if you go down a little bit more, Shelley, that airway management, we'll have to get that in. So kind of the same verbiage as the prior slide. And we'll be able to move that stuff because of the supraglottic can actually go to AMT. So if we just do it with the airway management portion of it, I think that'll be reasonable. So for EMT, paramedic, interestingly, the dexamethasone dose in the state standards was max of 16. For some reason, Central Arizona only had it as 10. I'm not sure why. They probably, I don't know why they put it as 10, but ours is consistent with NSEMSO. The other question I had is we had on our stuff, consider EKG if they're not improving. I didn't know if that was a historical thing that's not in NSEMSO. So I wasn't sure why it was there. I didn't take it out, but I didn't know if there was any historical relevance to it, unless you were worried about like a CHF or something else.
I don't recall the historics on that. I think the basis for the dexamethasone was, I think when we had talked about this previously, most of us said that we maxed out at 10 milligrams in the hospital setting. I don't know. I don't do much pediatrics. For those that do it, at least in adult patients, we tend to max out at 10 with our dexamethasone dosing.
And just an FYI for the EMT, for the kits, the drug boxes, they have an optional 8. So just to throw that in also.
This is Jason. Yeah, I agree with Gail. I think it's kind of like the ibuprofen where we had all just said, we all use 600. We did kind of do the same thing from what I remember with dexamethasone is everyone said, yeah, it's a higher dose, but we really only give 10.
Okay. And that's fine. I mean, we can switch that down to 10. I don't have a preference there. And like I said, drug box has a minimum optional of 8. So they're not even going to have, unless they double their dose.
And I like the idea that Amber had and what we talked about going back to basically having the range. But will that mean on the previous protocol, do we need to go back and put the range back in there as well? I know it's going back 1, but we're on the epi where we had 2 to 5. Will we need to go back and change that since that's kind of the consensus?
Yeah, we'll go back in just a second.
Okay. And then, so the 12 lead portion, do we want that or not? I wasn't sure why it was there to begin with.
Yeah, if it's not on the SEMSO, I would suggest removing it. I don't know how many of you folks are getting 12 leads on these patients. I don't think I ever have in 15 years.
Nope.
Okay. I didn't know if there was some historical reason that we had kept it in. So we should take that out. As far as the supraglottic and intubation, so that verbiage is going to need to match the prior one, and then that'll move up. And pretty much the rest of that box outside of the dexamethasone should be similar to the prior slide, correct?
Yes.
Okay.
We'll make that change.
So that was it with croup.
And then the max dose for dex will be 10 milligrams.
And the max dose, if you wanted to switch that to 10.
All right. So kind of going back to the epi discussion under So one option for this would be 1 milligram / ml, comma, 2 to 5 milligram. Is that what you're referring to for the range, Amber?
Yeah.
And then within the parentheses, do we, let's put 2-5 ml.
Mhm.
And then for the field paramedics who are wondering, who again emphasize the importance of dose consistency and simplicity, just to clarify, we agree, and I think we can have an opportunity to make this consistent across both pages, croup and bronchiolitis. But the reason you see us going to this range again is again just to reiterate Dr. Bradley's point. This particular protocol set we're working on is meant as a reference for medical directors statewide who are looking for just information on where to start. And so your specific agency medical director can use that and then tailor it to the needs of your agency. That's the intended audience for this particular protocol set we're working on today.
So just to make sure everyone is comfortable, I would like to hear from someone in the field. Does this verbiage, is this confusing, or is this a reasonable verbiage based on recognizing that you may have different concentrations and different amounts that you carry? I'm going to start calling on a few people that I know are, let's see, I know Matt Shaw was on shift.
Yeah, I'm here, Dr. Bradley.
Oh, perfect, Matt. I'm calling you out.
Yeah, I think that makes sense.
Okay, thank you. And I see, so I see Mark Hansen, field provider makes sense. Sandy, that makes sense. Vince, reasonable. Okay. Thank you. I just want to make sure, sometimes when we make these changes administratively, I just want to make sure that if someone's taking care of a child that's critical, that we're not putting out something that's going to be not helpful to them. All right, so I see Mike Patton also weighed in as well. Okay, James Cunningham, thank you. Okay, so it looks like we've got at least 5 to 6 paramedics who have said that this works from a verbiage perspective.
And just to be clear, for those paramedics who supported the decision, anytime any paramedic in Arizona comes and complains about this now, I'll make sure you 5 siders.
That is recorded on the meeting. Just a reminder.
No, we really do appreciate your input. These decisions only become stronger because of your engagement. So thank you.
Hi, it's Brian. I have one other thing.
Go ahead.
On the dexamethasone, that's an optional drug. Should we have in front of that to consider instead of just an outright statement?
I don't know that we've used consider in front of other optionals, have we?
I certainly understand the point. I don't recall doing that just based on the drug list. And again, it was very helpful to kind of have Dr. Bradley reiterate the idea, which is, this is a reference set of protocols. And so if the decision is made to add dexamethasone, then the agency medical director would need to make that adjustment in their own approved drug box as well. So I'd probably leave it as, no, my sense would be to leave it as is. Anything else, sorry, on this one?
No, that was about it for it. I think I moved some verbiage to the EMT just for them to advance for airway stuff for supplement. Yeah. So suction and then move from nasal cannula and advance to keep oxygenation. That's it. So pretty much the same. It would look pretty similar to the bronchiolitis at the end.
Okay. I have one question for the group. I'm wondering why the Nasemso set calls out epiglottitis as a specific exclusion. I'm just trying to figure out how relevant that is in clinical practice from a pre-hospital medicine perspective. The only thing I can come up with is maybe they want to make sure we're not aggressively attempting to intubate patients with epiglottitis in the field. I'm not sure how helpful it is to add that word back in, or if it just adds confusion.
We have it in, it's in on bronchiolitis also. So it's in both guidelines.
Yeah, I'm looking at the old set from 2019, and we don't have, we have epiglottitis under an exclusion for bronchiolitis, but not under Strider.
Correct.
Franco, this is Amber. I agree with you. I think in the pre-hospital setting, it's not something they're going to be probably aware of.
We can
Yeah.
take it back out. I mean, that was the one that was, questionable to begin with. And it's the lowest one on the list anyway. So it's not like it's super high.
All right. Any other comments, Shari, before we bring it to a vote?
Nope.
All right. So all those in favor of adopting the Pediatric Strider group protocol as is shown, all those in favor say aye.
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 Any opposed? Any abstentions? All right, that will carry. Next page, please.
So Franco, do you want to go back to bronchiolitis and just consider the updated epidosing to match on the two guidelines? I know that was voted on, but just to make sure that we.
Yeah, thanks for the reminder.
match.
Yeah, thanks for the reminder. So we'll just change the dosing to match. Are you going to ask us to vote again on that change?
Yes, I do think we'll need a repeat vote.
Okay. All right. So while she's doing that editing, can I get a new vote then? All those in favor of adjusting the epinephrine dose to match both pages? All those in favor say aye, please.
Aye.
Aye.
Any opposed? Abstentions? All right. Thank you.
Okay, so for Bruley, we had now I know you guys had gone through it fairly recently. I tried to bring it up with just, so there were two ways to look at it, and I actually talked to Gail on it. So for the inclusion, they're a little bit more we were pretty vague with what our inclusion was initially, just an episode that was frightening with a combination of the first three items. Whereas Nasemso is a lot more specified in what they're considering. So we can either go back to the basic one, or this is Nasemso's version of it. And then the only other part of the inclusion that we did not have was any altered level of responsiveness. So as far as taking it in pieces, anybody have an issue with the inclusion portion? Like I said, ours was pretty brief.
So
I didn't know what was easier for EMS. If we want to make it a lot more, I mean, I guess if we want to generalize it like that, it'll be, we'll capture a lot more kids, and we won't miss, but you're you kind of increase your numbers with it versus limiting.
So I don't think we need less than 1 year because that part is covered by the exclusion. Exclusion is greater than 12 months.
Okay.
So I think that part is covered there. So it could just be, and I think it does make sense to say infant, an infant versus patient, just to again clarify. So under inclusion, I would say after an infant, take off less than 1 year old, just because it's covered by the exclusion. So the top line there.
Keep an infant.
So an infant, and then with an episode. And I guess my question is, does it have to be brief?
That's their definition of it.
So, okay, so infant take off less than 1 year old.
They have it listed as sudden, brief.
Not working?
Plain.
Yeah. Okay. No. Oh. All right, so I'm gonna hit up our Pete's folks here.
Well, so yeah, I was going to mention, it looks like Dale's back on the call, but from my standpoint, I'd almost argue remove the less than 1 minute, but the definition, the medical definition for Brewy really does, it's very specific. And the age factor is very important. The suddenness is very important. The briefness is important, and the resolution is important. I almost feel like the less than 1 minute starts to split hairs that may create a patient safety issue.
Okay. So we can take out the less than a minute and just keep it as a brief episode.
So can you guys see the updated verbiage here? An infant with a brief episode that is frightening to the observer, which is unexplained and completely resolved.
Yep, that looks good.
And then I added in, they had specified for color change, not just, cyanosis or pallor, but not excluding like just acrocyte, like, just the hands and feet. We can keep that in, take it out. I don't care. I just threw that in as a reminder that was specified there.
Yeah, that's going back to the resources that are intended for hospital-based providers. Brewy excludes things like red and purple, but includes cyanosis and pallor. Very important distinction.
So you can keep that in then. And then we didn't have altered level of responsiveness. That was not included in ours. I'm not sure why. So I put that in.
Same thing.
Sorry, we do have that in the Central Arizona one.
Yeah,
Central, but it wasn't in the state.
Yeah, it wasn't in the state. It wasn't in the last T3G. So adding that back in is totally appropriate.
And then the only other one, so we had our exclusionary. So NESEMSO has like this huge exclusionary list. I narrowed it down and left it so there's not as much. I mean, I would rather have them include versus exclude, especially when we're talking about things like, differentiating breath holding spells and gastric reflux, so I kept all that out, but I did move up. If they have a history or exam consistent with child abuse, I think we should hyperlink at that point, because even just the history of it should hyperlink to abuse and maltreatment, and that excludes them out of this category. And they need to come in anyway.
That's a very thoughtful change, and I certainly would support that.
As far as the rest, see, as we go down, universal care, hybrid, okay, that stuff was all pretty much the same. The only thing, so I changed a little bit here. So we talk about taking them to a baseline readiness center for children. However, they now have highlighted these high risk criteria. that if that's the case, they're actually recommending going to a pediatric facility with a critical care. So now I'd like to hear what our PEDS colleagues think of that, but they're saying considering transport to a facility with pediatric critical care capability for any of those high risk criteria.
So I think, Shar, because these are statewide and there's many parts of the state that would not have a pediatric ICU available to them, I think we do have the kind of pediatric prepared centers of different levels.
Mhm.
So I wouldn't want them to think that they now need to fly all these kids to a
Right.
PICU type center. So I would be in favor of the previous terminology. Do you have what that looked like before that really specified? Because we feel
It
like the
doesn't
pediatric
specify any of
prepared.
it. The only specification on it is that regardless of appearance, they should all be transported to a facility with baseline readiness. So similar to the line above.
So,
That's all we had.
okay.
So we never they just in this version differentiated the high risk criteria.
So, okay. So you're saying, so given possible need for intervention, that's unchanged. The next bullet, consider facility with this. So for kind of geographic areas where they do have a PICU available,
Correct.
we want to say for pediatric critical care capability, if available, would be
Yeah.
one other option to add in. So if you are just saying Pima County, Maricopa County, and you have a PICU that's readily available versus going to a community ED, that may be preferential.
Correct. So, and it's a consider, not transfer to.
Mhm.
So.
And I see, I also see that Dale has a very good point in the chat as well about the child abuse part.
And I actually put that above. So, I mean, do we keep it again in EMT? So we can keep it again as I mean, because it's so important, we can double, I mean. I'm going to change this from consideration.
Yeah,
Which
and I'm sorry, I read it. It's up in that blue section.
Yeah.
History exam consistent with child abuse. Arizona revised statute requires that we report when we have concern for child abuse. So I think consistent, I think the bar is higher. Whereas concern, the bar is a little bit lower, which again aligns with statute a little bit better. It's terminology, but I think the threshold should be low for consideration.
So instead of saying history or exam consistent with child abuse, the last bullet, you're saying concern for. History exam.
Concerning for, concerning for
child abuse. Right. And then that'll hyperlink them to the other where it should go through a much more detailed. That works. And then if you go down a little further for the EMT, the only other things that have changed. So the supraglottic stuff, I mean, I guess what we can do is we can just move that up to AMT and put in a, because I moved everything else up that just maybe if airway, just start with bag valve and then, or for respiratory distress, similar to before, we put in just the airway management piece.
Agreed. Make the language as consistent as we can with the others.
Yeah. And then we put in just refer to management one, but we should have contact for medical refusing. We used to have Let me see if I kept it in there, regardless of, yeah, I did. Appearance, they should all be transported. So all the other bullet points that had previously been in, I just moved up and put it in the appropriate spots.
Where did you put the regardless one? Oh, at the very top?
It's up in EMT because
Oh, yeah,
EMT
right.
should have
Yeah.
that consideration. It shouldn't just be a paramedic.
Agreed.
So those were the main changes with it. Just the high risk. We added on the exclusionary for abuse, changed a little bit of the inclusion, and the high risk criteria.
All right. Any other comments on this page? All right. So all those in favor of approving the guideline as shown, please say aye.
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 All those opposed? Any abstentions? All right. So this guideline is approved. Next, please.
Okay, so the last one is pretty wordy, and I don't know how to make it less because it's multiple pages. I was able to get it on one page, but that was cutting some stuff out. So we started it on our guidelines. If you look at our actual guidelines, that we start as if there's no concern for resuscitation, whereas I threw in that if the first point should be if there's need for immediate resuscitation, then the cord needs to be cut right away. So, I mean, obviously, if you've got, you have, a prolapse, whatever it is that you may need that. So, and then how to do that. And then if no resuscitation's needed, we had wait 30 to 60 seconds. Guidelines are saying, up to 60. If they're a good, if it's a reasonable delivery where they're term and they're doing well and you can give the extra time, and then do the warm dry stimulate, wrap them in a towel. As far as the
Sorry.
Yeah.
Sorry, just to cover. So there is in the OB one specifically, and this was an SM, so there is a little bit of overlap. So they do say that even if immediate resuscitation is required, they still do say to try to keep the newborn attached without clamping and cutting the cord.
Okay. So we can
So-
change that. Do you want to change that back then? Or,
Yes.
okay. Then just take it. What I would do then is so you want to wait. So we're just waiting 30 to 60 seconds regardless.
Yeah. So the last version
Take out
just
the first two lines. So what you're going to do then is you're going to move clamp the cord in two places and cut between the cords to that'll go to the second line. We have that listed as completely separate, but I don't know if we're going to have room. And then we'll take out if immediate resuscitation we'll take out the whole first line. And then we'll just take out if no resuscitation is required, the wait part. So erase that and then get rid of that line. You can take out if no resuscitation is required and just start with wait. And we can add in then 30 seconds back in.
So, and one of the things in the OB one,
And I didn't
They-
look at the OB, sorry.
that's okay. There is a little bit of overlap. So they actually they recommend 1 minute. So changing that, they said after 1 minute clamp cord, and then they say to 5 to 6 inches from abdomen,
Okay.
which is,
So that's interesting that they're completely different on me. Let me
so
pull.
just a
1 minute,
consideration
5 to
here.
6. Yeah, I see where you're
Yes.
at. I just pulled it up.
We're gonna do a time check.
After birth and then clamp at 1 minute. Okay, so we could take out the 30 to 60. So keep that there. Wrap infant in the towel, keep head covered. They changed for weak cry. if signs of respiratory distress with obstruction, suction mouth, then nose, routine suctioning not recommended, where we had originally if thick mac or secretions are present. So I just changed that portion. Now, the other part that's a little bit different, the way that they changed it in the guidelines, they have specified this ventilate, evaluate, and then resuscitate. It doesn't flow very well as part of the issue. So they start out with, the way that it changed was, essentially for heart rate greater than 100. They've got blow by, look for cyanosis, do the blow by, monitor for respiratory distress, and kind of in the middle of that area, ventilate if needed. And then under the subtitles of heart rate less than 100 and less than 60, they have it specified as evaluate and resuscitate. I'm not sure if it has any added value though. Which is
And
why
you're referring to the Nasumsa verbiage?
yeah. I wasn't really sure if that helped much on, when they're looking at it as the protocol. I didn't think it had a lot of value the way that it was done, and I wasn't sure how to break it apart or if it was really even needed. Because we have all of the pieces of it in there. So essentially, at greater than 100, you're monitoring for it, you're giving blow by. If there's signs of respiratory distress or you're starting BVM. And then the other delineation that was new was you're starting with room air initially in term and late term. Otherwise, if it's preterm, you're going to 100% with a goal of 85 to 95 at 10 minutes. Whereas if heart rate's less than 100, they don't specify in there. We can put the verbiage back in though, that you're still using room air in the same situation unless you're after 90 seconds, and then they're not coming up if they're in between that range of less than 100 but greater than 60. Does that make sense what I'm trying to say for the O2 sat? Even though they don't delineate it, it's the same, that you're and they're talking about fractions, but otherwise 100, you're changing to 100%. So you're starting at room air unless they're preterm. And then as far as the resuscitate, that really didn't change at all. So I didn't add in the, like I said, I didn't add in what they, as far as their delineations of the ventilate, evaluate, and resuscitate. I just didn't think the cues were as beneficial.
So I guess the one question that I would have for kind of the field providers, and please, Dale, correct me if I'm wrong. I'm just concerned if we have a neonate that they're considering resuscitating, how many field providers are going to use room air to bag the neonate versus oxygen, and how much of an importance that is clinically.
I'm sorry, Gail, was that question for me?
Yes, sorry, Dale.
Yeah.
So in this section that we're looking at on the second bullet under if heart rate greater than 100, I'm just concerned that in the pre-hospital setting, with the rare times that EMS is delivering and then resuscitating a neonate, essentially a newborn, do we really want to add this verbiage about using room air for late in term versus 100% if they're preterm?
Right.
We can just leave it 100.
Yeah,
or just basically end it where we ended it before, which is to basically say BVM ventilation with room air is what it read previously.
Yeah.
I'd leave the goal. I'd leave the SPO2 goal though.
That's fair.
Yes. Yeah, I agree.
So take out use room air through 35 weeks. So just delete that sentence, I think would be probably a little bit more.
It's a little easier for them. That's fine.
Yeah.
And then we can then for the next one, then take out, if no improvement after 90 seconds, change to 100%. Because if you're already assuming they're at 100% when the heart rate's greater than 100 and they have cyanosis, if the heart rate's less than 100, the assumption and they're using a BBM is that it's not, that they're already at 100, right?
Well, the first one is saying initiate BVM ventilation with room air at 40 to 60 breaths. Goal SpO2 at 10 minutes is 85 to 95%.
But what we're saying with the first one, when their heart rate is fine and they're in respiratory distress, we're just saying they're doing 100%. We're assuming.
That's not what it reads right now. That's why I
So
want to make
initiate BBM at, okay, so at 100% room air. So here's the question is so the first one, if we're saying that they're going to be ventilating with 100% anyway, then do we have initiate with, so we're keeping it at room air then? Or for the first one with heart rate
Yes,
greater than 100?
keeping it room air.
Okay, so then they're not going to bump it. So if their heart rate stays over 100, they're just keeping it with room air regardless. They're never going to bump it up.
We have a line that says goal SpO2 at 10 minutes is 85 to 95%. So hopefully,
Okay, with the assumption that they'll increase it. Okay. And then, so starting at room air and then, okay, then we can leave it that way then. And then CPR and reevaluate. And then if you go down, the only other changes was, I don't think we had any other changes. I think I added into ours, we didn't have the repeat epidose. So the epinephrine's every 3 to 5 if heart rate remains less than 60. We didn't have that in ours. Central Arizona had that in though.
That's, yeah, good add on the repeat dosing. I don't know that we need to apply cardiac monitor because that's part of our universal guidelines.
Oh, okay. So then we can.
I think we can take that bullet off.
That off. Okay.
But yes, I could pick up that we need to add in the repeat dosing timeframe.
Okay. So you just take that one out. And then the second part of it then is the second page. I didn't know. I was talking to Shelley. I don't know where it comes from as far as where did we get the flow sheet? Did we make this flow sheet?
that was added by the pediatric consultant just to have a different way to visualize it as an added
Right.
value.
So if it came from the neonatal resuscitation algorithm, that was updated. Granted, the update to it is a little bit different, but amount, there's only a couple things that are different. I didn't know how it worked with changing it or updating it. So, you know, most of it's pretty similar, except, you know, now we have like SGAs instead of just straight intubation.
Yeah, in fact, I was going to ask you to pause here, Shari. Can we go back to the page before and ask the group if we want to create a more nuanced verbiage with the AEMT? Is there, are we going to, is there an AEMT supraglottic airway option that needs to now be defined?
Can we do it similar to what we've done? Just refer to it as an advanced airway and move that up?
We
and
can
then also we need to move the fluid bolus to AEMT.
Yeah, yeah. So this needs a little attention.
Thanks
here.
for that pickup. Yeah.
Yeah, so we need to study that carefully and just make sure that by matching the other two guidelines that it reads clean and is appropriate.
So I would say, because the first bullet under EMT and paramedic is apneic or significant respiratory distress, consider endotracheal intubation per local protocols, with many agencies having transitioned to supraglottics. Depending on the size of the neonate, if it's a significant preemie, there's likely not going to be a supraglottic that would fit. But for many normal sized newborns, the smallest size supraglottic would work. So if apneic or in significant respiratory distress, refer to airway management. How does that sound as a?
Yeah.
Yeah. And then what we can do is Right, and that would go under the AEMT one.
Yep. And then the next line probably needs to say advanced airway is recommended as opposed to intubation is recommended.
So
Yeah.
the next bullet.
Yeah. Instead of intubation,
Yeah.
advanced airway.
Advanced airway.
And then that'll allow you to remove your next sentence.
Right.
If intubation, yeah, perfect.
Now, if this is all going under the AEMT, then that last bullet of for endotracheal and endotracheal tube, we're
We
making
could
the
just say
assumption that,
paramedic only again.
yeah,
I kind of like the fact that we have it there just as a quick cognitive reminder. So
and
people aren't-
actually the reason it was like this is it is all under AEMT paramedic. It's like all together. So it was together. That's why it was all in the one box. Because the guidelines are, I mean, for those two. So it already had been under the single.
So I, yeah.
auspices.
The
Are you
IV fluids were there before, but
Right. No, what I mean is that AMT and the paramedic, these are the same guidelines. It was just changing the airway portion of it. So all of them can do it.
yes, this is all going to get moved under AMT. We're just not going to do that real time adjustment.
No,
now.
what I'm saying is with the boxes together, like I don't know how to make it so it's so you put I get I see what you're saying. The
Yes,
paramedic-
Shelley will take care of that piece.
Yeah. That was just me looking at it thinking it was already there because that was my mindset when I did it, that it was all one.
No.
Okay.
All
So
right.
yes. So there will be like the lightish blue gray color under AEMT. The IV fluid section would go into that for AEMT. And then we would have the if apneic or respiratory distress, refer to airway management with the
Right.
Hyperlink. We will delete the consider endotracheal intubation. That line should be deleted. First bullet
Under there. And
Yes.
then there
Yeah.
is no EMTI paramedic then.
yes.
Okay.
Correct.
Got it.
Correct. Everything here should be
Is
moved.
shifted up. Okay. I was just below instead of above.
Okay.
So
Yeah.
there you.
Yep.
Okay. And
So
then
the only part that we need to consider is if we keep the line about newborns greater than 2 kilos.
Right.
With the endotracheal tube size, we would need to add back in the EMTI or the paramedic section. That's
But paramedic only, like we have in other pages.
but it's EMTI too.
Oh, I see.
yeah.
Hi, it's Brian. So yeah, the IMT and the paramedic box need to go back in there for all the epinephrine doses anyway.
So epinephrine.
Yeah, those should be under AMT, right?
No,
No, these
That's
are the
for
cardiac.
cardiac.
only EMTI and paramedic.
Yeah,
Got it.
only for because they're apparently they can't do the cardiac. So then under AMT would be fluid bolus and the apneic respiratory airway management. And then, yeah, it's just the question on the newborn part. Unless you double it and you put something specific under EMTI paramedic and redo the advanced airway again in there, just as like a consideration, newborns.
So real time, okay, just gonna stop right now. We will real time moving these boxes. We will not be able to do in a meeting. What we can say is where things are gonna go. So all
Right.
the IV fluids and airway component is gonna go under AMT section. All the epinephrine will remain under EMT and paramedic.
Right.
The question to the group is specific to the newborns greater than 2 kilo. Do we want to include the endotracheal tube size information? That's really the question, because if that is, then we need to put that in the paramedic section. The question is, do we even want to include that in this? Is
Is
that
it
from
in the airway
December?
management? Do we have anything in that in the airway management? I don't have it in front of me.
I can look at that.
I mean, honestly, you guys, we can delete the whole sentence. I mean, if we were trusting folks to just look up their size references on whatever adjunct reference they have on scene, they can figure it out.
Yeah. Yeah. So the first two bullets and the last bullet will go under AMT. The rest stays in paramedic, and I think we're good there.
I have it in the recording to edit that way.
All right, so the question on this box, this algorithm, was this produced by someone, Franco? Do you remember, or did this come from an actual resuscitation program?
As far as the graphic itself, I do not know. The contribution came from our pediatric consultant, but I don't know who created or if it was a cut and paste as far as the graphic.
So it looks very similar to the neonatal resuscitation program guidelines. That said, I don't know what copyrights are. I don't know how to change it. There's like a few small changes. Most of it's pretty similar. But, we have on there specifying consider ET intubation versus and now it's like laryngeal mask or supraglottic device. And then, do we want to, at least if you are looking at, the updated, so the updated reference from that program, the version 8, which was 2020, has like a few extra things, like for the epinephrine, just putting in the box, every 3 to 5, and heart rate remaining less than 60, and considering hypovolemia and pneumothorax. And we don't have I have that there. But for the most part, everything's similar.
So can I maybe suggest, if Shelley, can you pull up in the SEMSO page 161 and 162? So we go to the bottom of 161. This is from NASEMSO. So we've got these, it talks about intervention indicated based on your assessment. And then if you scroll to the next page, it's also got a nice projected pulse ox in infants over time with time since birth and projected pulse ox. I'm wondering if this would be more useful than the potentially copyrighted algorithm that we have.
And their algorithm includes, actually, when you look at their algorithm, it includes the targeted oxygen saturations table. Like they have that included on it, on their flow sheet that looks similar to ours.
And Shari, when you say they, you're referring to
The neonatal resuscitation algorithm, like the program itself. But like I said, that's like a program, and I think it does go through AHA also. It's got through AHA also.
So one consideration would be that we adopt the tables instead of that algorithm. So table 1, if you can scroll up. And then table 2.
The only thing I would change well, I guess table 2 has 10 as 85 to 90%, or we're saying 85 to 95, but
And this is just kind of projected increase.
yeah. Just don't want to confuse. I mean, I guess what the question is what is easier for them to see? Is it easier for them to see it as a flow sheet going through, or is it easier for them to see it as the table and queue it? Because I think that was your purpose originally, was to give them a second alternative in something like this.
I'd like to suggest that, again, the T3Gs being a reference, maybe this is a medical agency, medical director level decision if they want to change visual appearance, or if they get feedback from their own crews. They're certainly, free to do that. And we can keep ours as simple as possible.
I mean, I'm not adverse to using just the tables. The tables were actually pretty good.
Yeah, I think especially table 1, if you can scroll up just a bit there. I mean, it's basically telling you.
Yeah, I would just say let's adopt the tables as a new value added component there. Remove the graphic flow chart and leave that up to an agency level decision. They know where to find these references. Any other feedback on that, or can we go ahead and leave it up to Shelley to create something visually to show us later at a later time?
I think it would be just copying and pasting those 2 tables, correct?
Yes, with that, but we don't have any room, right? So we're gonna have to make a second page.
It would replace the current page 2.
Yeah. Okay. So replace the current page 2 and then move and then adopt it that way. Does anyone have any additional comments on this page, or can we move to a vote?
The only question I do have looking at it, and it may be just me looking at it, in the central cyanosis box for BBM with the yes, no, and maybe it's just me, so it's saying at 60, you're going to do a BBM, at 100, you're not. And then it's just us teaching to range of when they would, or am I just reading this wrong?
If I understand this correctly, it sounds like what that's trying to say there is that you should do bag valve ventilation at 60 to 100, whether or not there is central cyanosis present.
Okay, that's
correct.
okay.
The reality of it, child's braiding, they're going to be cyanotic, so it's kind of a moot point. But the heart rate defines that threshold of positive pressure.
Yeah. So maybe I don't know if we cut and paste it, then it's going to stay like that. If we make our own table, then we can say yes or no, just to make it more clear.
I mean, maybe it was just me. It just didn't seem super clear.
No, I think it's a valid point. It took me few seconds of staring at it.
Yeah. So maybe just wording it differently.
Yeah, I would maybe suggest if we make our own tables, just putting yes or no, if Shelley doesn't mind us having, adding more work to her list, as opposed to just cutting and pasting a graphic.
Okay.
I've got a note on that if that's the vote on the group.
All right, any other comments? Can we move to a vote? All right, so let's go ahead and vote to approve the changes to neonatal resuscitation, including removing the flow chart from page 2, replacing it with a couple of new helpful tables from the SEMSO guidelines. All those in favor say aye.
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 Any opposed? Abstentions? All right, that's approved.
So, Franco, in the interest of time and the fact that Dr. Woolrich kindly offered to join us, we have 1 hour left. I'm wondering if we could cover his 2 sections first, just to make sure that we cover those today, since we will likely need another special session, if you're okay with that.
I'll allow it.
Thank you, Franco.
Dale, do you want to run us through your changes?
Yep, go ahead.
Oh, yes. Yeah, I'm sorry. Yeah, it was just verbiage, to be honest with you. I thought guardian, and you can see my changes are in the red font. I thought guardian was more inclusive. It had originally specified parent, but sometimes a child may be a ward of the state, or the actual guardian attendants may be a grandparent. So I just thought it was more inclusive to say guardian or caretaker. And the verbiage is minor changes. Those were the first 2. I don't know if anyone wants to comment on those first.
Dale, Mike, I do have a comment or more of a question on this. And I know that this gets to some legality, which is obviously none of our fortes.
Yeah.
But this comes up page after page after page, and it would certainly create a huge value in terms of space saving if we could make this a universal verbiage change across the entire document. I just wasn't sure if your proposed changes, safely and sort of medical legally captures what we're trying to say with a wide enough umbrella.
You mean as far as legal authority or the legal guardian? I don't know if that's necessarily, and again, maybe I'm just reaching beyond the focus of what we have here, but Arizona Revised Statute allows an individual or an interested party to stand in loco parentis. We don't necessarily ask parents, are you the legal guardian or are you the adopted guardian? Or so if someone presents themselves as the guardian or the parent, I think it's more inclusive. I would defer to your expertise as far as, the pre-hospital legalities, but I think guardian encompasses what we would expect a parent to be and then some.
Yeah. And I may be overstating the problem. The reason why it's sensitive to me is because I was in charge of the refusals guideline, and there I certainly could use an opportunity to save some space, and it would be nice to make it consistent with this page in terms of the sensitivities of a refusal on behalf of a child.
Yeah, refusals. I think you're right. the burden is a little bit higher in that regard, because they're actually refusing care as opposed to promoting the care. Maybe taking caretaker out and just using guardian. Caretaker can be a little bit more nebulous. I agree with that as far as that term is concerned.
Okay.
I think for this one, I like the addition because this is a very specific patient population. And if you scroll just up a tiny bit here for our inclusion, these are really patients with functional needs, and their caretakers generally know their functional needs. So there's many times these individuals may be at some type of specified daycare or facility with a caretaker who's not their guardian or parent. That might be very helpful. So I think in this setting, as it's not the refusal guideline, it's very specific to functional needs. I like that addition that you have, Dale.
Thank you. Yeah, I agree. I'll echo that. Special healthcare needs, the caretaker is informed and educated about the child's condition. The individual's condition, whether adult or child, and how they're being managed, with whichever device or special need they have. So I agree.
Great points all around. Yep. All right. Anything else other than the verbiage? Anybody else have any comments, or can we bring this to a quick vote?
The last bullet, if I could, was items of comfort. I think of Peanuts, where they had their special blanket that they wanted with them. With patients with cognitive delay, sometimes there are items that allow them to be more comfortable. That may not be medical devices, but maybe a teddy bear or something like that. And that was the purpose of that addition.
No, that's very thoughtful. And I agree, an important adjunct for the care of these patients. I mean, it could even be an electronic device in many cases.
Yeah.
All right. All very helpful changes. Can we go ahead and bring to a vote without any other comments? Not hearing any other comments. All right, so we'll go ahead and vote to approve. Can I, all those in favor of approving the changes to functional needs as shown, say aye.
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 Any opposed? Abstentions? All right, thank you. All right, we're taking a look at abuse and maltreatment now, Dale. Thank you.
You may need to scroll down the seat on there with the comment. And scroll down on the actual guideline to the 10.4 component.
Sorry, I was muted there. My only comment was to just 10.4 is an excellent rule. I'm very glad that we included it. I just wanted to correct some of the lingo in regards, or the language in regards to it. It's really less than or equal to 4 months, inclusive of the 4-month age range. So it's really under 5 months. The acronym works because it applies to also 4 years of age. So that was a comment. So my change was, if you can see right under the green font line, it says any bruising on a patient less than or equal to 4 months, torso, ears, neck. The acronym, and they further studied and validated a component of the acronym was FACES. So now it's 10.4 FACES. And I think that was the other thing I had in my comment line was torso, ears, and neck is the rule, but there's also frenulum, auricle, cheek, eyelid, sclera, and that's the acronym FACES. So the medical tool that's been validated is now 10.4 FACES.
Do we need, is there an update to that graphic? Because that graphic was a cut and paste.
Yeah, that is an older graphic that doesn't include that.
Is there a new one available reflecting what you're saying?
I'm sure there is. Whether or not it's intellectual property or whether or not we can get permission to use it.
Yeah.
That's the question, but they're definitely out there.
Okay, so I see Shelley putting some notes to herself to research that. Anything else on this page?
I think that was it.
All right.
Yeah, I really liked the guideline. So
Yeah, that was again credit to our pediatric consultant,
Yeah.
Julie, who made that suggestion the last
Yeah.
time we reviewed these. All those in favor of adopting these changes with the caveat that Shelley will work on updating the 10.4 faces graphic. All those in favor say aye.
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 Any opposed? Any abstentions? All right. Thank you, Dr. Woolrich. We very much appreciate your input today.
Yeah, I appreciate it. Thank you guys so much. I'm going to go ahead and sign off. Okay. Thanks, everybody.
Thank you. All right. Should we go back to the regular agenda?
Yeah.
Let's see. Is Matt? I know you're on shift, but are you back on the line?
Yes, I'm here for a little bit at least.
Okay.
So this was a new protocol request that came, I believe, from the central region. Is that correct, Dr. Bradley?
Yes, this was created in the central region. This was adapted from the original COVID guideline. Once the declaration of emergency was rescinded, the thought was to still keep some type of guideline in place, knowing that we still have COVID in the community, but also wanted to cover other highly infectious organisms as we've had things like H1N1 and other illnesses. So this is very similar to the original COVID guideline that was approved at the state level. The format is the same as well. If you scroll to the top, the biggest difference is that it is not just listed as a quote, COVID guideline any longer. It's really more specific for patients with known or suspected highly infectious respiratory illness. So that's kind of the basis of it.
Yeah, and I thought this made pretty good sense, and I didn't have any additional comments to add to it.
All right. So does anybody need more time to review what's on the slide? Otherwise, we can bring it to a vote. All right. Hearing no comments, all those in favor of adding this, so just to be clear, this guideline's already been vetted and is currently in use for the Central Arizona protocol set. So content-wise, this is already a vetted patient care process. So all those in favor of adopting and including in the T3Gs at a state level, all those in favor say aye.
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 Any opposed? Abstentions? Okay, the motion carries. Thank you. Next.
So this in the top blue box there, you'll see reference to that previous guideline that was sort of added in there, if suspected COVID, influenza, et cetera, and then a hyperlink to that. I looped in a little bit of the Central Arizona's verbiage at the very top, but otherwise it's largely the same as it was previously in that box there.
So no substantive changes in terms of patient management otherwise from the Central?
No, sorry, I just meant that blue box.
I'm sorry. Okay.
Hold on, I did make some other suggestions.
Got it.
So I added the NIPPV CPAP under EMT, which was not previously included, as well as monitoring pulse oximetry and end tidal, and kind of removed the pediatric section altogether and just looped all of those things within that EMT box as a whole. Suction the nose or mouth if there's secretions, and place in a position of comfort were the two things that previously were only listed under the pediatric kind of subcategory there. And those seemed pretty pertinent for all age ranges. So I added them to just the one.
That's great.
You can scroll down a little bit further, please.
Sorry, we're just adding STR next to the NIPVV. Thank you.
I'd also put the suction portion higher up than the non-invasive part, because you're gonna, that would
Right.
be the first thing to try.
Sure. Yeah, that's correct.
And then, do we have like any other type of oxygenation listed in before that to try before we get to non-invasive?
Yeah, it says provide supplemental oxygen.
Supplemental, okay.
Yeah.
So I was just gonna say, keeping the same, if we want to keep the same verbiage as some of the other
Correct.
protocols, which had it kind of spelled out on how to advance it, or we can just leave it. And I just didn't know how, for consistency, how you wanted to do it. Because on the other ones, it's supplemental oxygen escalate from nasal cannula face mask to non-breather is needed in order to maintain normal oxygenation. So I'm just trying to think of.
Yeah, if we scroll down, so I'm looking at the old version, and the old version does include a line about escalating. And then yeah, scroll down just a little bit more. There we go, right there on green. So maybe we can get that moved up to its appropriate position up top.
So,
It'll need some wordsmithing there, but yeah.
can we just go back to the top and undo that just for a second, just so we're not going up and down too much. So going back up to this one, just line by line it. So there's a couple other things that I don't know. Matt and Shelley and I met yesterday. So we no longer have patient assist, but so we need to remove the assist patient with own medication.
Right.
So we do have the option of albuterol, still is an option. So I just want to make sure, sorry, that we capture and cover some of this. So albuterol is an option for EMT. So
Do we need to specify a dose then? Just move the line from AEMT up to EMT?
yes, so it should be.
So we'll need to massage that because we're saying that they can give it either by nebulization or MDI.
So
I don't know what would be the appropriate way to do that.
Or inhaled, so 5 milligram nebulized or inhaled.
And then we need to capitalize albuterol.
So
Does the ordering matter? Like, we've got a medication up top versus, I mean, does it make a difference, or do we not care?
I mean, we'd like to be consistent. So if you see something that is out of order, let's definitely try to be consistent formatting. So like we have initiate universal care, provide supplemental oxygen.
Yeah, I would say the albuterol goes below the airway positioning and suctioning.
Yeah.
Yeah.
Just, yeah, I usually keep medications kind of, yeah.
Yeah.
Here.
What?
And shouldn't pulse oximetry and Untitled CEO to go up above the meds?
Albuterol.
Agreed.
And then I have one other question about that particular line, because it has STR on the whole line, but it kind of might make someone think that pulse oximetry is an STR when it's only Untitled CO2. Unless there's another way to label that to make it clear it's only for Untitled CO2.
I mean, we're going to get into space issue on this one. We might be able to, it would have to, I think that's about as clear as we can.
Yeah.
I see your point, Brian, but outside of making it its own line, I don't know that.
Can we bold the entitled CO2 and the STR then? Maybe that would,
To show that it's linked.
so that it, yeah, just bold that. Or that would work too. And
Just to throw one other thing in, looping this back around to the pediatric stuff. For the non-invasive, we have it listed under AEMT. We don't have it listed under EMT with the STR. So do we need to move it on the other ones then too for the airway stuff? Right, for bronchiolitis and croup, didn't we put it under?
Yeah,
So we
I
keep
understand
it
what you're
uniform.
asking. I'm just looking back at my
Okay.
scope of practice chart here.
because it's not an STR under AMT, so I think we just weren't including the STR in there.
I like having the STR in there for clarity, just personally.
Right,
So if we need to go back and put it in the previous one, I think we should, just so it's consistent.
Because if that's the case, we need to move it to EMT. Because right now it's listed under AEMT.
So wait, on the one we're looking at, it's under EMT. So let's maybe focus on this one first, and then we can go and adjust other ones and re-vote on those, just so we don't confuse. Because right now we are in the airway bronchospasm. It's under EMT. So
Okay.
if we scroll down further, just keep scrolling a little bit. Then we've got the NIPPV again listed here. And that section we moved previously to that whole kind of airway stuff. We had moved previously to the AEMT section.
Yeah.
So NIPPV down through BVM ventilation bullet could all be. And then we can just, again, nuance the intubation and circulotic and just say advanced airway like we've done previously.
And then do we want to take out the initiate end title since you have that already in the EMT section?
Correct.
And then ipratropium is that still an, I'm trying to remember, is the ipratropium an STR with EMTs?
So so medications are not STRs.
Or okay, I mean within scope, I should say.
Yeah, sorry. So let's see. I'm looking right now.
It has it listed for EMT.
It's an optional, correct?
Right. So could we maybe put that one up to the ipratropium up to the albuterol, underneath the albuterol, and yeah, up there.
Yes, we can. And we'll fix the formatting piece of it, but we'll just kind of paste that here for now.
Okay.
So
Well, Shelley, before you move away from the EMT box, just again with respect to order of steps, where did you guys just put it? The bullet that Brian asked us to move up, monitor pulse oximetry and entitle CO2. That should probably just come right underneath initiate universal care, because you won't know what the SATs are unless you're monitoring them. Yeah, basically just cut and paste that line.
okay. And then, so Shelley, it's monitor, so that monitor pulse ox and title should just be higher. So it's the whole line.
Yeah, just cut and paste.
I'm sorry. That's okay. So let's, some of this stuff we need to kind of focus on more the content piece on this. Otherwise, we will never get through this in the next year and a half. All right, so kind of going back to the section, this is specific here to STR. The AEMT section here, this is the part that we had talked about will get moved to the AEMT section. And then we will just make we might need to make some adjustments because we do specify BPAP, which is our version for saying BiPAP here.
We want to take a potty break for the.
We only have 30 minutes left, so you can take one. So we'll fix the formatting piece here. But if we have this, obviously the BiPAP line would need to come out because that is not going to be in this section for AMT. Refer to airway management, supraglottic. So this could be advanced airway should be utilized only if BVM fails. So what does the group think about that verbiage?
I like that.
We'll fix all that verbiage stuff. Formatting. And then under paramedic, we could just delete this and that would just be so for agencies that have the ability to use BiPAP. Kind of goofy, but that's the only way I can think to utilize it since we're trying to combine AEMT, EMTI, and paramedic.
Yeah.
Yeah, I think that makes sense.
And then did we lose our fluid bolus? I'm sorry, no. There was a caveat in the prior version about only placing an IV or IO in a pediatric patient if there's clinical evidence for dehydration. Did we lose that somewhere?
That got just moved up to the AEMT box as a whole.
Got it. I see it. Thanks. I
Yeah.
can't see straight anymore.
Can you move down to the paramedic box one more second, please?
Yes.
Okay, forget it. Nope, it's on there. Thanks.
And the last change, at least for conversation anyway, was under magnesium sulfate. Depending on which guidelines we looked at, there was a different time domain that the medication was to be administered over. It was anywhere from 5 to 20 minutes. I couldn't find any evidence that really supported a specific time frame. So 5 to 10 is, after talking with Dr. Bradley, is what we kind of settled on, but up for discussion.
And to give a little history on that, the central region who has kind of actively used these for quite some time, that's been one of the biggest complaints was each of the different magnesium had variable kind of dosing as well as variable rates for administration. And so the group had thought, let's just make it 5 to 10 minutes, which gives a reasonable enough range without it being too fast, but also it's understanding that most crews don't have pumps. And so dripping something in over 20 minutes is highly unlikely. So once they're hanging mag, typically these are pretty sick patients. So that was kind of the range of for duration and rate that was kind of approved at the central receptor.
Brian, this is Franco. From a long transport perspective, any idea how often your personnel are getting that deep into this algorithm where they're giving mag?
Well,
Just
I
anecdotal.
don't know that we've used it a lot, but I think the 5 to 10 minute is pretty reasonable. rather than.
Yeah, I'm just trying to think. I don't know that I've ever seen a paramedic give magnesium for bronchospasm.
We see it all the time.
Yeah.
Well,
We get-
it's way on our treatment guideline, it is way down the list, and that's why I've only seen it a few times.
Yeah.
Right. This is Jason. It's the same way. The ones that are closer to our hospital, they don't get to the mag. The ones who have the hour-long transports, they almost always get to the mag.
I see.
I would say at least we've got two hands behind us in the room who are saying that they use it frequently. And I would say at least where I work clinically, we get magnesium given for bronchospasm a lot.
I see.
By EMS.
Okay. Yeah. Thanks for the feedback.
I see Sandy. I'm guessing that's you. You're now showing an S for Sandy, but it's frequently in Pinal as well.
Got it.
Yes, that is me. I'm sorry. For some reason, it keeps kicking me off, and I've signed in about 3 times now.
Not I saw that, so I figured that was you.
And I think those are the only changes.
It's Brian. I have one more, I think maybe technical thing. If you can scroll back up to the EMT section. So we have monitor pulse oximetry and Untitled CO2 and STR, but it's only an STR for EMTs. Everybody else down below, it's in their scope of practice, I think. Let me check the EMTs here real quick.
It is. I think that could be covered under universal care unless we want to specify it as well. But it is in scope for AMT and up. But it could just be kind of considered part of your universal care unless we want to really specify it in the airway management, which is reasonable since it is important. I think once we being Shelley fixes all my formatting glitches, we may be able to fit in another bulleted line if the group thinks it's important.
All right. So if you guys handle that technical change after the meeting, anything else that we need to adjust today from as far as clinical management content? Any other comments?
Yeah, I'd still go back to the pediatric guidelines. So the way that we have it laid out is that the airway stuff doesn't come in until AEMT for non-invasive. So if we're doing it this way, I think we need to be consistent with how we're doing it. So the other ones will have to change if we're happy with it being up in EMT with STR.
Yeah, Gail, how do you want to do that procedurally? Do we have to go back and vote on that change?
That would probably be cleanest. What we can do is approve this one if the group feels comfortable approving it, and then we can copy and paste and go back and look at the other guidelines.
Okay. All right. All those in favor of the changes as shown to the bronchospasm page, please say aye.
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 Any opposed? Abstentions? Okay, that is approved.
All right, so if we can go back to the bronchiolitis under peds first. All right, so for this one, what we're considering is adding in the NIPPV line. Is that correct, Shari, with the STR?
Yeah, so let's see, if you go to, so we'd have to add it up higher. So right now it is, we have advanced airway, BBM. We were going to change part of it, did not delay in administration. Did we get rid, where did some of it go? Hold on, let me find my original.
Was it it was bronchiolitis.
Weren't we including that in the airway management? It was going to all be defined in the airway management.
Mm-hmm.
Which then we could take it out and just refer to the airway management and the EMT on the one we just did, and that way we're not having to change multitudes of these.
And the EMT box refer to airway.
Before we make any changes, let's see if we would like to do.
Yeah, this is like,
So, I think one of the caveats that we have talked about is that while we do like to refer as many things as possible, there are some guidelines where if we're asking a paramedic who's taking care of a sick child to go from one guideline to the next, that might not be ideal in the setting of trying to actively manage a patient. If there's times where you are now going down to very specifics, that may be more appropriate.
So essentially we have listed. So for respiratory distress, we just listed as refer to airway management, whereas previously, and do not delay administration for non-invasive. Previously, it had been put in on the original guidelines as severe respiratory distress, non-invasive, positive pressure, or high flow. We were taking that out because the high flow was for paramedic only. So the option we have then is if we want to rearrange it, we can do similar to what we just did with the other, where we put in, if requiring, if BVM fails, respiratory failure, consider that would just be CPAP with STR and airway management guideline. And then under AEMT though, so I guess that would sit for AEMT, and then when you hit paramedic, and under AEMT would be, I guess, a more advanced airway, and then for paramedic high flow. But then we'd be splitting in 3 spots.
Sorry, this is Matt. I'm just curious. Like, this is for 2 years of age and under, correct?
Yes, bronchiolitis is 2. Yes, correct.
So I'm just curious, like up here anyway, like we don't do non-invasive positive pressure on kids that young. And I don't know anyone, I'm not sure anyway, about anyone ground agencies in the state that are doing CPAP on a 2-year-old or even have access to high flow nasal cannula.
And we can just leave it if it's not being utilized and you guys don't have equipment for it.
Well,
then
but
we can leave it.
I would push back on the high flow nasal cannula at least, because that is something that
That's
is
paramedic.
available for that age group. And, it would be nice to have the document be able to grow for any, for at least a little bit, in case agencies start to look at that and try to adopt that.
So I would argue that this verbiage for this age group is reasonable. It does refer you to the airway management right here. We're going to fix this. We'll get shifted to the left. Just imagine this across here. I can't do that real time, but that would be off to the left. Refer to airway management. This would be bolded here. People, let me change it. Well, nope. Anyhow, this would be bolded, take us to airway management. And under airway management, you would, under paramedics specifically, have the option for a high flow nasal cannula. So I think we do get there with the recognition that high flow nasal cannula is not equivalent that many agencies currently carry, although I think that's going to become more common in the next few years, especially as we start getting more inexpensive disposable options for this. So I think we have this covered pretty well in this section without making changes. The only question would be, do we add the line that's right here that we have for bronchospasm? Do we add this little line here, NIPPV? So if I copy this, do we want to consider adding this here or not? And that was to Matt's point, most people aren't doing this except for high flow, which would be paramedic only. So I think I would say that this would probably confuse things versus adding a benefit. I just wanted to show people, but I think I would recommend keeping this without that.
So we can keep it out now until the next, especially if most aren't using it.
Yeah,
and it's
I
not
would say take it out. I don't think many agencies, if any ground ones, have the capacity or events that would be able to appropriately provide CPAP to a child that small. If there's other providers that do, please correct me, but we don't, and I don't know anyone else that does.
So Shari, did you want to talk about it here again for croup?
Because croup, they can potentially be older, so there may be a mask that fits them.
I think I would be hesitant to have an EMT
Then let's leave it.
using
Let's leave
an
it then.
IPPV. Yeah, I just kind of think about the fact that, you know, typically if you've got a child with croup, they always say not to agitate the child. You come with them with a tight fitting positive pressure mask. I think that would agitate most
Then-
kids, just a scared kid.
I mean, I think it's fine that if we're saying we're differentiating, that's fine. I think it's reasonable to leave it off.
Okay. All right, so back to our bronchospasm. So did we take a vote on that or not?
Yeah.
So we did, okay. I think we could go on to the next one then. Try to maybe knock out one more. What is
Great.
next?
Pulmonary edema. So again, just the comment in the blue box about the highly infectious airborne respiratory illness to go to that protocol. And then under EMT, again, the addition of the NIPPV and the monitoring of end-tidal CO2 and pulse oximetry, which we might need to reformat now based on the previous one.
And also a comment to just be sensitive to the order of the bullets to reflect practice like we did with the previous slide.
Yeah. I don't think I changed anything in the AEMT. Scroll down a little bit farther. Yeah. And then just again, the addition of the BPAP there. So,
Can we go back to the nitroglycerin? On this one, I just as a general comment on my cardiac pages where nitroglycerin is coming up, and we were very careful about listing the contraindication to erectile dysfunction, specifically PDE5 inhibitors. The new NASEMSO guidelines gets a little bit broader, not only with PDE5 inhibitors, but also prostaglandin drugs that are used for pulmonary hypertension. And those were all added in. And I was going to suggest to the group or present it as a question to the group as far as what they felt about that. So as a matter of consistency, you know, if we agreed that it was important, that might be something to factor in here.
Do you have a list of medications, Franco? So basically you're saying or pulmonary hypertension, or you're saying taking PDE5 inhibitor medication, or
Let me look up on the NASEMSO. I'm just trying to find out what page this is. Respiratory pulmonary edema 190. All right, so 190. Let me just I'm curious to see what NASEMSO said on this page. Management treatment. So that's interesting. So on page 192, I see the mention of nitroglycerin for pulmonary edema, and they don't seem to have any cautions. And actually, you know what? It makes sense because this is pulmonary edema from presumed CHF with a hypertensive emergency. So the patient's hypertensive and experiencing end organ injury from that. And so it would make sense that we would give nitroglycerin early and often and aggressively. And so maybe we remove that contraindication for nitroglycerin in this particular clinical context.
so, but
You know what I'm saying? Because I mean, this is pulmonary embolism from like a CHF emergency in a hypertensive patient. And this is generally not a clinical scenario where I would sit there and tease out who's taken Viagra and not give it. You know what I'm saying? I'd give it anyway to bring their MAPS down aggressively and quickly.
Any thoughts on that one?
This is Amy. I would be still a little bit hesitant in combining nitroglycerin with PDE5 inhibitors in the pre-hospital setting. I don't know. I still think I would be cautious with that.
I think my other thought is we really try to educate EMS on that from a chest pain perspective to not utilize the medication. Do we start confusing them as to, well, the patient's got chest pain and they're in pulmonary edema. Can I use it? Can I not? I think consistency, especially in the pre-hospital setting, might be more beneficial.
All right, so if you guys want to keep it, then Shelley, the quickest solution would be to just quickly go to my chest pain page and just copy paste from there. Because I included, they only specified a couple of prostaglandins, and I just wrote the text. Yeah, so wording from the chest pain, and that way it's consistent across the document.
So, are you ready for a vote on this one?
What do you think about
I am.
putting the EKG or ECG up to EMT with an STR? Are we going to do that across the board when anytime there's an ECG, or are we only going to do it, or not going to have that?
Oh yeah, that's a great point. Yeah, I did that with my cardiac ones as well.
Yeah, that's what I was thinking. Anytime there's an ECG, just make them all STRs within the EMT section.
Yeah, and in fact, I would recommend using the verbiage that I used, which mentions acquire, 12-lead ECG, and transmit.
Yeah, because even if it's a paramedic, I still would want it transmitted.
All right. Any other adjustments? And we are going to move the NIPPV to EMT. I see that there. All right. All those in favor of adopting the pulmonary edema page as shown? All those in favor say aye.
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 Any opposed? Abstentions? Okay, this page is adopted. Approved.
Franco, we have 12 minutes left. We have kind of two options. The airway management, I think, will take some time because we have updated scope and there is probably a lot we want to make sure this is pretty cleanly done. So I would recommend maybe we hold on this one and start with this next time around. The question is the RSI one, if you can scroll to that, Shelley. So this is one that we do not currently have in our guidelines that I wanted to have the group consider as to whether or not we include. This has been in the central region. I think it is a STR. So there is some, we've got STRs kind of more in the guidelines now, but for different parts of the state that are doing RSI, should we have a baseline guideline in place? So I think that's kind of the discussion point to start with, if the group's okay. And then if we don't have time, we can do this next time, but I just wanted to see, kind of get a gauge from the group if they want to even consider adding this, knowing that that's the background on it.
I like the idea of having it in there. We don't currently do any RSI, but we do have several paramedics who are also flight medics that have wanted to try to get a program started. So it'd be nice to have some basis for it.
Does the group want to try to tackle this in the next 10 minutes or table this till the next time?
I think I would agree that we should definitely this should definitely be included. But just based, Dr. Brelli, on your and I conversation the other day, like this was like almost half of our time together. I don't know if we would fit it in 10 minutes.
Fair enough.
Do Dr. States want 10 minutes?
I don't see his highlighted changes on his.
I
So-
made the changes.
Yeah, so one of the things that I think as we keep doing this process, we might want to just have highlighted changes more visible when we see it. So Dr. Spate did update the Epic TBI one, but when I looked at it, it's kind of got the updated version. I want to make sure the group can see the changes. I think we, at least for a first meeting of doing this in quite some time, got through a decent chunk. So Franco, are you good with us maybe ending at this point?
Yeah, that makes sense. These are sensitive issues and deserve careful scrutiny. Does anybody have any other thoughts or concerns before we adjourn? Gail, I just have a question. What do you foresee the process then for scheduling the next subgroup meeting?
So, one of the concerns that we have, since we got a couple minutes, if we get enough PMD members, we hit a quorum. And so the concern and the reason why we brought together this group was to make sure we didn't hit quorum issues. And then if we are voting and approval, then we do need to have a quorum. So I think most likely I would work with Shelley and try to schedule a few more meetings. Our next MDC, which would be the final vote, is in September. So we might need to add in another PMD section meeting in August, if not before then too. We've got the July meeting and kind of keep trying to get through as many of these before the September one. Does that sound reasonable to the group?
Yeah.
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 Great. So we will be on standby for further communications from you and Shelley.
Yes.
All right. Okay, well, thank you to those who presented today. Thank you for your hard work. I know that all of you guys are working hard on these. Shelley, double thank you for your work and your attention, taking these notes, memorializing these important changes. I'm excited to see the improvements in the T3G product. I think, based on the work I've done so far with this Nasemso version 3.0, some of the changes are strong. And I think overall, we're going to have a better product at the end of this effort. So with that, we'll go ahead and move to adjourn at 11:53. Thank you.
Thank you.
Thank you.
Thank you. Goodbye.